Say the child has primary amenorrhea. 1. The child is 15-year-old but not as it attained periods. It has developed secondary sexual characters. When child is 13 year but has no periods, it also has no secondary sexual characters. There may be many differentials with respect to primary amenorrhea. We consider a 17-year-old girl. Case 1, we have 17-year-old girl with the primary amenorrhea but has developed secondary sexual characters. So depending on whether she has breast development, axillary and pubic hair, uterus or sexual organs, ovary, we can divide it into many differentials. At the outset, which is normal, normal breast, normal axillary and pubic hair, normal secondary sexual characters with normal ovaries. The child may be having a obstruction to the outflow. It can be transverse vaginal septum or imperforated hymen. Both these things will have a cyclical abdominal pain. With imperforated hymen will also have bluish bulging membrane when examined per speculum. Then we have normal breast, normal axillary and pubic hair but no uterus. There is ovaries. Then you may suspect MRKH syndrome or Mullerian agenesis, which is normal 45XX chromosome, but uterus and fallopian tubes are not developed. Next scenario, you have normal breast with normal axillary or pubic hair. Normal uterus are there, but you see a streak ovaries. Then you may suspect Turner syndrome. Streak ovaries Turner syndrome, which is a chromosome of 45XO. Then you have normal breast, but there is no sign of axillary pubic hair, no uterus, no ovary, but you see testis, which is rudiment. Then you suspect a case of androgen insensitive syndrome, where chromosome is 46XY. Since they have Y chromosome, they will have testes. They will also have testosterone, but the patient have insensitivity to androgens. So therefore, development of these organs will not be adequate. Rather, this androgen is converted into estradiol peripherally, which helps in breast development. Since there is sensitivity to androgen, there is no axillary or pubic hair. Okay, this was a case where the girl has primary amenorrhea with the normal secondary sexual characters. Then you have a case of 17-year-old girl with primary amenorrhea and secondary sexual characters are not developed. Now look at the height of the child. Stature is normal or she is short. If the stature is normal, it may be a central origin or peripheral origin depending on GnRH, FHS and LH hormone. We can divide it into hypogonadotropic hypogonadism, or it can be hypergonadotropic hypogonadism. Both these conditions have decreased estrogen, decreased progesterone, hypogonadism. First, hypogonadotropic CNS only, there is decreased synthesis of LH and FHS. It can be diseases of isolated GnRH deficiency or it can be Kallman syndrome, where you see anosmia along with this amenorrhea and delayed secondary sexual characters. Or you can also have acquired causes for this, such as excessive starvation, excessive weight, exercise, weight loss, anorexia, or a case where increased prolactin, such as prolactinoma. It will inhibit GnRH and LHFSH production. When there is normal or increased GnRH and FHS, but still there is decreased estrogen and progesterone, you may suspect a case of ovarian failure. Okay, then we have a scenario same, but the child has short stature, that is 17-year-old girl with primary amenorrhea, no secondary sexual characters, with short stature. Same, you may have hypogonadotropic hypogonadism or hypergonadotropic hypogonadism. There is decreased FHS and LH with the decreased estrogen and progesterone. In cases, if congenital, can be a case of hydrocephalus. If acquired, any mass of pituitary or empty cella syndrome, it can be a tumor. If FSH and LH is normal, but still estrogen progesterone decreased with decreased height stature, you suspect that as a case of Turner syndrome. Chromosome 45XO, there is gonadal failure, not ovarian failure, gonadal failure as such. Streak ovaries are there, and also there is a history of short stature, height less. Then you have a case of 17-year-old girl with primary amenorrhea, but there is heterosexual development, that is the child exhibits organs which are maybe towards testis. These are seen in the normal 46XS, that is genetically a female child, but will have virilization, seen in congenital adrenal hyperplasia, as discussed. Okay, any congenital adrenal hyperplasia may be of enzyme 21 hydroxylase deficiency or 11 hydroxylase deficiency or 17 hydroxylase deficiency. Any deficiency which ends with 1 will have virilization, suspecting heterosexual development in a female